In terms of patient safety, I think policy questions are a little bit different. There's the one that we've been wrestling with forever, and that is, what are the best levers for improvement? That is, how do we get hospitals to do what we want them to do? We have used essentially persuasion. We have recently looked into things such as withholding payments for SREs, and we've required reporting and so forth. Are they the best? Are they the best methods, or are there better ones? Can we think of better ones? I think a fundamental question that some of us have been talking about for 10 years is, how do we get the CEOs involved? How do we get their attention and their commitment? You look at the how do they do that, hospitals, the 10 exemplars that we talked about. Look at those exemplars I threw up to you before: Virginia Mason, Children's Hospital in Cincinnati, Ascension, and others. In every case, the driving factor was the CEO who got it and who made it a commitment and made it happen. A person who understood and who had commitment and had leadership ability. How do we get that in 5,000 healthcare organizations or 10,000 healthcare organizations? How do we make the needed culture change? What is needed to make us become learning organizations, as Sengi says? And related to that is, how do we really have meaningful accountability? They all go together. So I think we've got some tough nuts to crack. I have a few suggestions. In healthcare, it seems to me we've got to deal with the McCallan phenomenon. I'm simplistic enough in my thinking to say there's something wrong when you pay twice as much for a bypass in Miami as in Minneapolis, and you get better results in Minneapolis. I don't know what Medicare's problem is that it can't give equal pay for equal work. But that alone, I think, I haven't done the numbers, I'm not an economist, but I think would probably solve the Medicare financial future problem. If we could get all the services in America done at the rate at which the best are done, we would save billions. I'm sure Elliot Fisher has an exact number. It's probably 254.3 or something. But the fact of the matter is, there's something fundamentally wrong about paying twice as much. But something fundamentally wrong about your tax dollars and mine paying twice as much for an inferior service in one area as another. So I think that we have to deal with that. Clearly, we have to make ACOs work. And we're going to be paying for quality. Everybody agrees with that, that we should pay for that. The question I have for you is, what's your role in that? Can Leapfrog make that happen? The answer is yes, you can. The question really is, will you? But you're the ones that are in the driver's seat on that, and you can say, this is what we're going to do. And if we do that, we can make it happen. So I think some of these things are really conceptually straightforward, but certainly not easy to accomplish. In patient safety, let me just say again that safety is part of quality. So whatever we work out for, the way we pay for quality is the way we pay for safety. They go together. We clearly need to do something about increasing accountability. I'm at the far extreme on this. I happen to believe in public reporting of all serious adverse events, not just SREs, not just HAIs, but everything. I think we've got to get to that. There's an old saying about you can use financial incentives, or you can use shame, public reporting. There's another option, of course, and that's regulation, which of course is a dirty word nowadays. But on the other hand, just stop and think about it. Don't you really think we should have an FAA for safety? Of course you do. Of course you do. There should be an FPSA to set the standards and enforce them. I don't have a great strategy for how we're going to accomplish that, but there's no question that's what we should have. Clearly, we need to give a lot more thought, talking about incentives, in terms of sharing the savings from improvements with the people who are making them. In Michigan, in that great experiment 5 years ago, where 68 hospitals had 0 infections in those 2 areas, they estimated they saved $165 million. And so my initial response to that was, okay, Blue Cross, did you give 82 of that back to them? And if not, why not? I mean, that's another sort of no-brainer. why not share the savings? I think some of the plans for the ACOs have in mind exactly doing that, but clearly we ought to think about that. In terms of getting at this issue of disrespect, one way to handle that is to put some sunlight on it. And one way to put some sunlight on it would be to have cops include questions about respectful treatment. You only have to have 2 or 3, and then make that public. I think we'd see some big changes if we did that.